Today, it's a privilege to have Professor Madhavan Rajan from Cambridge University Hospitals, UK, speaking to us on endothelial keratoplasty. I request his fellow, Dr. Rashmi Desmos, to introduce.
Hello, everyone. Good afternoon. Good evening there, actually. It's my personal pleasure to introduce Professor Madhavan Rajan, who is my current mentor at Addenbrooke's Cambridge University Hospitals. He has more than 25 years of experience in the field of ophthalmology, and he's done a fellowship in refractive surgery at St. Thomas Hospital first, and then a cornea and refractive surgery fellowship at Moorfields in London. Currently, he is the clinical lead of the cataract and cornea services here at Addenbrooke's, and he's also a professor at the Anglia Ruskin University at Cambridge. Proud recipient of the NHS Enterprise Innovations Award. He has a special interest in endothelial keratoplasty and endothelial cell transplantations, and we are looking forward to his lecture today on endothelial keratoplasties. Over to you, Professor Rajan. Professor Rajan, I think you are on mute.
Yeah, thank you, Rashmi, and thank you, Santosh. It's a very kind introduction, and it's a pleasure and privilege to be part of this iFocus program, which I think is a great initiative for people, postgraduates, ophthalmologists, particularly for distance learning, to bring the professional experience of many people around the world to ophthalmologists in the comfort of their own homes. So I think well done, and I shall look forward to actually looking into this program more in the future, being part of it now. So I hope you're all very comfortably sitting down in your own chairs, having a cup of tea or having a glass of wine, because it's probably about 8 p.m. In India time. It can be quite a relaxed presentation for the next 50 minutes, where I'm going to actually talk about one of the fantastic topics which has revolutionized corneal transplant field for many corneal surgeons around the world. So I shall share my screen now, and hopefully we can kickstart. Right. Please feel free to ask questions, and there will be somebody who will be taking these questions, and I will be more than happy to stay back after the presentation to answer these for you. As Rashmi mentioned, this is something which I have very closely followed over the last 15 years, and I shall share with you my experiences. But equally, I've prepared this presentation targeted on postgraduates to give a description of indications of EK, endothelial keratoplasty, description of the techniques commonly used, such as Desec and DMAC, and to talk about complications that are, again, commonly faced in this field, and of course, what awaits us in future in this field of endothelial transplantation. COVID might have had a significant impact on every facet of life, human life, but certainly it hasn't stopped distance learning. And I think there's been an explosion of webinar contents, and I think this is a typical example of how people can come together and share experiences and learn from each other. So I shall describe the early periods in learning endothelial keratoplasty as much as to where we are at the present time, including some research applications and implications to what we can expect in future. So what is endothelial keratoplasty? It is, for the very few who are not fully aware of this particular area or the corneal transplant field, it is a selective form of corneal transplantation. You might have heard about what people term as lamellar keratoplasty, as opposed to full thickness penetrating keratoplasty. You transplant only the necessary layers of the cornea, preserving the integrity of the rest of the host cornea, for all obvious advantages which we will see. So in simple terms, endothelial keratoplasty is replacing diseased human corneal endothelium with a functional and anatomically preserved human corneal endothelium on a Desmos membrane derived from a cadaveric donor cornea. There are various terminologies which has been used in the past, but presently I think we have settled down to the fact that two commonest techniques that are widely followed around the globe is what they call the DSEC and the DMAC techniques. DSEC is short form for what they call the Desmos stripping automated endothelial keratoplasty, where a semi-automated device is used to procure the endothelial graft. DMAC is just using the Desmos membrane to replace the diseased host endothelium. So these are the two techniques that we will be talking about fairly in detail in the next few minutes. The indications for EK is for corneas which has had decompensation or loss of transparency related to endothelial diseases. It could be as simple as that. And I've described a few typical examples where you have endothelial decompensation leading on to bullous keratopathy in advanced cases. Depending on which part of the world you live in, certain conditions predominate your EK practice. In the West, in Europe and Americas, Fuchs corneal endothelial dystrophy is one of the commonest indications for EK. That might not be the case in the Far East or even in India for that matter, where pseudophakic bullous keratopathy unrelated to Fuchs might be the predominant reason for EK practice. Equally, other ocular surgeries or repeated ocular surgeries injuring the corneal endothelium leading on to decompensation forms another big indication for EK surgery. There are other few examples which are rare and which are not very common, but still where endothelial keratoplasty has become the gold standard for practice, such as eye syndromes, herpetic endotheliitis, and very rarely age-related endothelial failures. This is the table which shows you the common endothelial dystrophies. Again, as mentioned previously, Fuchs predominates this particular group of conditions where this is the commonest indication where I am in Cambridge and where in Americas, Fuchs, particularly the what they call the complex, the late onset Fuchs condition is the commonest indication for EK. Just to put some figures to it, in the UK, there are about nearly 4,000 transplants undertaken annually. It used to be pre-COVID. Things have changed now with COVID, with very poor availability of transplant tissue for PK or any indications. But generally, about 4,000 transplants are undertaken annually in the UK, as compared to US, where about 35,000 are undertaken. And now lately, when I looked up your literature in India, it's about nearly closer to 50 to 60,000 transplants being undertaken in the country. The demand is rising with all these newer techniques, and of which the EK proportion of transplants in the total corneal transplant performed in the West, the EK almost has gone beyond the 50% mark, where 55 to 60% of the total corneal transplants performed in these countries are in the EK group. So you can imagine how important it is to any budding corneal surgeon to understand and know the technique of EK in one form or the other to treat the patients with endothelial diseases and disorders. This is a diagram which simply which shows the differences between a full thickness penetrating keratoplasty, where the entire diseased host cornea is removed in a defined area of 8 or 8.5 or 9 millimeters, depending on the condition, and replaced with a full thickness donor cornea, which has got preserved all the layers of epithelium to endothelium. That is penetrating keratoplasty, and I'm sure all of you are aware of this. As opposed to endothelial keratoplasty in terms of DSEC or DMAC, where only the recipients, the donor endothelium on a Desmos membrane, with or without the stroma, the posterior corneal lamella is transplanted to the diseased cornea. And the biggest difference between the DSEC and the DMAC is the fact that in DSEC you have the posterior stromal lamella attached to the Desmos membrane, and that forms the Desect graft, as opposed to the DMAC, where it's Desmos membrane with its endothelial layer. So this is the big difference between the two techniques where it is done for endothelial decompensation. So Desect and DMAC. And the advantages are very, very clear. When compared to penetrating keratoplasty, endothelial keratoplasty preserves most of the patient's own cornea and therefore the tectonic integrity and all the other advantages which are related to it, which is described here. The tectonic stability, there aren't that many sutures that are required to secure the transplant. In fact, there are no sutures required to secure an endothelial transplant, and you will see how. Reduced astigmatism risk, and the reduced rejection risk because they're tucked into the eye and not exposed to the external environment and to the blood vessels of the limbus. These transplants have a further immune privilege against immune-mediated rejection. And you will see the percentages in PK and the EKs later on in the presentation. There's reduced risk of expulsive hemorrhage, which is not common, but equally not uncommon in a full open sky in penetrating keratoplasty procedures. And of course, the fast visual recovery, which has actually taken everybody by the storm. A penetrating keratoplasty procedure takes months for visual rehabilitation in relation to suture-related astigmatism, removal of sutures, the refractive elements of the PK, as compared to a EK procedure, where the refractive stability and the visual stability is within a few weeks to a few months and to a much more normal levels of 6/9, 6/12, 6/6, depending on the type of procedure. So these are the biggest advantages of an endothelial keratoplasty procedure, which has made EK the gold standard for any endothelial disease over and above penetrating keratoplasty. Still, there is a role for PKs in a very small proportion of patients, and again, we will describe those later on in the presentation.
Start videoing.
So this is a technique of Desect, where Moria microkeratome, which is it's a manual microkeratome, which is used to dissect the anterior lamella of the donor cornea, and what is left behind is the posterior lamella, which is trephined to the required diameter to get the endothelial graft. Now, what I'm taking out is the anterior lamella. There are a few devices which are available to do this. As you've seen, there is Moria microkeratome, there's Gebawa, which is much more automated, where you do not have the speed of the microkeratome pass is set in a Gebawa, where you do not actually deal with that. Whereas in Moria, it's the speed of your travel determines the thickness of the graft that you get. So there are two different microkeratomes to secure the Desect, the automated endothelial keratoplasty graft. Typically, the endothelial graft, the Desect graft, looks like this, where you have actually got the posterior lamella, and you've actually marked an F on the stromal side to know the orientation of where the endothelium is and which is the stromal side. And you've flipped it in such a way that the endothelium is facing you, being uninjured during the storage process before it is transplanted into the patient's cornea. Having secured the Desect graft, which is now endothelium facing up, it has to be loaded onto a particular device for safe transfer from outside to be delivered within the patient's eye, so it can be floated up to attach to the patient's posterior stroma, which has been stripped off its own Desmos membrane. So in a Desect procedure, you prepare the transplant, you make sure you've got a good graft, and then you take the patient on and you remove the patient's Desmos membrane to 8 or 8.5 millimeters, and then you transfer this endothelial graft, which has been loaded onto what we call a TAN glide, and this is a suture pull-through technique where you're actually now inserting this graft into the patient. So this is a suture is a tenoproline. This used to be the way how we used to insert these grafts to start with, but things have moved on now and we use a forceps, and you will see how that's done. So I'll continue on with this video, and you can see the way how it's drawn on. So it's well preserved and well protected within the TAN endoglide tube, and it's actually pulled into the eye using the tenoproline, and the tenoproline is cut after that, and an air bubble is placed underneath the graft, which has been folded with endothelium facing downwards towards the iris the normal way, and then the procedure is completed with a complete airflow. This is another alternative way, which is what we follow now. We use a tan glide. We still use the tan glide, what we call the ultra thin tan glide, and we actually pull the graft in as compared to a pull through. And this is done by a microforceps, which are designed for DSEC purposes. And again, with the mark which is on the stromal surface, you know which side is right and which side is not. And if it's not the right side, you pay attention to it and you flip it within the eye to get the endothelium facing the iris. Okay, the normal endothelium configuration. So this is another video which again shows that how this graft is pulled through with a suture and folded the way how it is. And you can see that there will be an air bubble picture in a minute. So there are a few insertions. Typically, there are a few variations to the preparation of transplant, DSEC transplant using a microkeratome. Insertion devices, there are a few choices. You have the Busin, you have the endosaver, you have the tan endoglide. Each one of them, there are preferences of different surgeons, but it is important to know that there are a few devices now available to safely transfer the prepared endothelial graft into the eye. Gone are those days when people used to fold it and pull it in or push it into the eye to unfold. This is once the transplant is transferred into the eye with the right orientation, stromal side up, then the transplant is positioned in such a way where you're covering the defect where the Desmos membrane had already been removed from the host corneal, posterior cornea, and with an air bubble fill, with an air fill which could last anything up to 10 to 15 minutes, up to about 50 to 60 millimeters mercury. You provide a good air fill to attach the DSEC transplant with no need for any sutures. And then you release the pressure and still retain the air bubble for up to 2 to 3 days, but without producing too much high intraocular pressure in the postoperative period. When people have access to intraoperative OCT, you can actually look at the graft interface. You can actually make sure there aren't that much fluid accumulation in the interface or air. And you can do quite a few clever things using the intraoperative OCT, including orientation detection without the need to mark the anterior stromal surface with gentian violet or vision blue. So that's a typical Fuchs preoperative cornea with mild stromal thickening, not too much bullous, but certainly has got stromal thickening. We would call it early to moderate corneal decompensation. This patient could have a visual acuities, anything ranging between 612 to 618 Snellens. And a good DSEC transplant can deterge the stromal hydration, can bring it back to normal limits. With a graft which could be anything up to 150 to 160 microns. And this used to be the early days when we used to train in DSEC, and it used to be a fantastic procedure compared to PK. But then when people started to do more and more of these, they realized that there are limitations to the conventional DSEC with a very thick graft. And there were so many aspects which came to fore in terms of learning, the learning curve, the graft stability, the handling of the graft and the insertion devices and thickness and everything else. So there were quite a few factors which were identified in the early years. Now, we are going back about a couple of decades now, and several factors were identified as to what limits vision in a post-DSEC cornea with a functioning corneal transplant. And certain things which were put forward, which included the graft thickness, the interface, which could interfere with the quality and the quantity of vision achieved post-operatively in a successful DSEC procedure. So typically, researchers, these are published work by many people. They're looking at the thick corneas, the thickness of the graft, the total thickness of a DSEC cornea, the posterior curvature of the corneas which has had a DSEC implant, the hyperopic shift, the increasing curvatures, the irregularities and the higher order aberrations that induces. All these factors were looked at very carefully in different publications to identify the reasons why a conventional DSEC cornea doesn't usually reach a 6/6 visual function. There are some cases which do reach, but majority of them are limited to 612, 6/9 parts. And that was a frustration to quite a lot of people because it was not a complete, a total visual rehabilitation of vision in people who had early or moderate corneal decompensation. Now that led to quite a lot of advances in this particular field, to think that if only we could get this Desec transplant to be as thin as a Desmos membrane transplant, then there's a likelihood of making some way into better visual outcomes. So that was the reason why a conventional Desec procedure advanced to what they call the ultra-thin or the micro-thin Desec procedures. So people were trying to devise many modalities by which they would make a reliably thin. When we say a micro-thin or ultra-thin, they mean a sub-100 micron Desec graft. So the thinner, it's logical to think that thinner the graft, it is more akin to the removed Desmos membrane. The Desmos membrane is about 10 to 15 microns thick, and you replace it with another 15 to 20 microns, it would be great. But at that time, DMAC was not available. So the next iteration of Desec was finding a way to get ultra-thin Desec. So that was the next phase of this endothelial keratoplasty procedures. We saw several variations, and I'll come to that in a minute. When we were doing the Desec cuts, even during those days, we used to realize that there are certain, in certain situations, we got a very thin cut, sub 100 microns, sometimes 50 to 60 microns, and we were overjoyed by getting a thin transplant. And paying particular attention to factors such as donor thickness, the chamber pressure, the speed of the microkeratome pass, the foot blade depth, and of course the surgeon experience. When we looked at all these aspects, we realized as a combination of a few factors, when they all came together, we reliably started getting thin grafts. And one of the biggest factors, which was very variable at that stage, was a donor thickness, which you don't have control on. You're faced with the human corneal donor that comes into your operating theater. So if you get a 600 micron donor cornea, you'll get a thicker graft. If you get a 500 micron donor cornea, you'll get a thinner graft. And unless you change the foot blade from 350 to 450 or 400, which weren't available during those particular times, and it wasn't reliable because they can cause perforation, you ended up having a thick Desec transplant. So we realized actually the variability was significant with donor thickness. We could regulate the other factors. So there were several techniques which were put forward. Ultra-thin Desec came along with a double pass microkeratome, where you pass once and then again you pass another microkeratome with a smaller depth blade to get a much more thinner posterior lamella. It came into some level of attention, but then again, it is not currently used very much. There were a lot of variations. There was a lot of there were issues with the with promotion of this to become mainstream way of doing ultra-thin Desec. There were microkeratome blades, and you saw the Gebawa, which became more automated in terms of the speed of the pass, with much more thicker, deeper blade cuts, with 400, 450, which started to actually produce even better, reliably thin cuts, but not without the compression and the pressure on the endothelial side. We came up with another idea of actually controlling the hydration of the donor corneas before we put them on the microkeratome, and what we call the Microthin Desect. So all these ultra-thin, micro-thin, nano-thins, all these things are basically thin Desec techniques. Instead of getting a variable thick Desecs, which are anything above 100 microns, thin Desec techniques have one thing common in themselves, is to produce a reliably, predictably thin cuts every time you slice a human donor cornea with a microkeratome. What we realized was that there was a significant correlation between thickness of the donor cornea to the thickness of the graft. The thicker the graft, the thicker the Desec, the thicker the donor cornea, the thicker the Desec graft. So we thought if only we can control the thickness of the donor cornea, then we would have actually controlled one of the significant variables which leads to thicker grafts. This was the idea. So what we did was, I mean, I'm showing you that picture of the gentian violet staining of the corneal human endothelium. Now, this is pre and post-op. When you actually cut these corneas, we don't pay much attention to the staining pattern of the endothelium. It's not normal practice, but during research work, when we started to do pre and post staining after the microkeratome pass, there were quite a lot of significant staining post-pass, particularly so when there's significant amount of pressure induced and to make that cut, and the deeper and deeper cuts. So they do injure the corneal endothelium during the process of creating a Desect transplant, so no doubt about it. So as I said to you, the thicker and variable the donor corneas, even with controlling all the factors related to microkeratome, you will still end up having a very variable Desect thickness. So the idea was this, very simply, just blowing some sterile air, using a particular way and particular distance and particular diameter on the donor corneas placed on an artificial anterior chamber, you could actually control the anterior stromal hydration to get it to a reliable, predictable donor thickness without injuring the corneal endothelium. So we came up with the pachymetric control stromal hydration prior to the microkeratome pass as the idea, which will lead to reliably thin Desect transplants. And so this is a technique which gives you that sterile air, which makes that stromal dehydration. And when you see this, when we control all these corneas to a target of 4, 5, 30 microns prior to microkeratome pass, you started to get reliably and repeatedly 100 micron grafts. And I won't dwell on this too much, but this is a technique which we published and we talked about it and reported on our outcomes during the early years, what we call the Microthin Desect. So you can see that we saw that the thickness was much more controlled, the graft thickness, and therefore the vision was much more controlled. And quite a lot of patients in our, up to 99% of these patients were around the 6/9, 6/12 mark. And that was very encouraging to see. There weren't that many detachment risks. So the standards were set in our own practice that we should be getting in patients who do not have ocular comorbidities with simple corneal decompensation. We should be aiming to get 6/9 Snellens in 98% of our patients, as I said, without any retinal comorbidities. There weren't that many, none of the grafts were lost to this process. Graft detachment rates were considerably lower. It was 5% and less. Primary failure rate also was lower in following the technique of thin Desect. But moving on to the next iteration of EK, despite making all these efforts to get very thin grafts, which we spent several years trying to master this technique, still, when we know that this eye could see 6/6 or can actually see better than what we got, there were still questions amongst many corneal surgeons. And this is where you have to thank Garrett Mellis for all the inventions and fantastic ideas and promoting an idea into a clinically translatable technique, which is now globally followed, which is fantastic to see. So thanks to him, and they came up with ideas of what we call the present day DMAC, because they want to make things better. So you can see the way a conventional Desect transplant got better with Microthin Desect transplant, and even we got even better with a like-for-like replacement of a Desmos membrane being removed and Desmos membrane being replaced. So I'm feeling a bit lonely here, so I'm going to stop and ask Santosh if I'm all right. Can somebody shout out that you're hearing me all right?
Yes, it's going beautifully, and I think everybody who's online are really enjoying themselves. That is why we don't have too many questions right now. So I think we'll take it in the end.
Well, sometimes you don't know whether you're talking to an audience or whether you're talking to your computer. So
No. All of us are glued to the screen.
Good, excellent. Thank you, Ritika. Thank you. So moving on. So you can see, I hope I'm conveying the way how things are evolved as to how and why this is important, because things haven't stopped here and it will continue to evolve. But it is the quest for becoming better and looking at really minutiae and wanting to give better to our patients, wanting to get better out of the techniques, and always that quest to move one step forwards. which has created this EK becoming Desect, the thin Desects, and the DMAC. So I think that applies to many forms of treatment within the eye field. So going on to DMAC technique, so I'm describing the DMAC technique now. So in DMAC procedure, so you score the endothelium. So unlike Desect, where you're putting it on stromal side up and cutting into the microkeratome, here endothelium's facing up, and you score the peripheral Desmos membrane and you peel it. Okay, so you will see the next slide is actually you score the periphery, you release the periphery, you peel the Desmos membrane, and then you trephine it to a desired 8 millimeters, or my preferred one is 8 millimeters. It could be 8.5, 8.25. So you trephine it to a 8 millimeters, and unlike a Desect, which has got the stromal substrate, a DMAC scroll has got no substrate, so it will roll immediately, and it will roll with the endothelial side outside, which is funny. And we still haven't totally understood why that elasticity coil, once you release it, once the attachments are released, the Desmos membrane scrolls with the endothelium on the outside. Very important anatomy to learn. It looked very simple to you, but it is jolly hard to actually get the first few cases going. They're very easily tearable, so you've got to be very, very careful. Very little margin for error, and the case is lost if there is a small tear and things like that. So you've got to be very careful. Once the transplant is prepared, like the Desect, you need to have a way to actually transfer this DMAC roll into the eye. And here we are using a Guida injector, which is now very, very commonly available and is very nicely used by many people. And you can see that it is a scroll, and you got to see the orientation of the scroll where the endothelium is facing outwards. So you've got to actually put the scroll in the right orientation, where tapping maneuvers without any air will unscroll it, endothelium facing down onto the iris. And this is a challenge. And visibility is key. You can actually get a nice scroll, but if you can't see through the patient's cornea properly, or for whatever reason intraoperatively the visibility is compromised, your case is finished. So just have to be very, very careful. And once it's in the eye, a few taps and the maneuvers of such nature will scroll it the right way. You get an air bubble. I normally use an SF6 in these cases. These are very thin transplants, so you want it nicely attached to the posterior stroma. And again, this is an example as to how you prepare the scroll. Once they are floating in water in BSS, you stain them so visibility is better. And we've done some work on what's the best stain to use and how much to use and what's the toxicity levels. So again, typically like Desect, plenty of refinements. Every single step had been looked upon by experts in the field, and to look at graft size, whether it needs a PI so that you don't get pupil blocks and pressure rises, what kind of injectors to use, what kind of air tamponade is helpful in Desect and DMAC. In DMAC, typically an SF6 is used widely because they tend to detach more because they are very, very thin friable tissue, and little undulations in the anterior chamber would be enough to actually detach these transplants postoperatively. And standardized graft preparation so that you don't do many graft wastage and graft losses minimized, and of course staining the graft with vision blue or the membrane blue dyes. So standardization of these procedures has led from significant complications reported in DMAC to very hardly any, and better vision. These are types of DMAC roll orientations you could get, and one has to be very careful looking at the roll within the anterior chamber to know which way it is, and then roll it the right way before unfolding it. So it can throw lots of challenges, and you should be really prepared to go through quite a lot of angst in the early few cases. But once you're top of the learning curve, which I would think is about 20 cases, then you know exactly what to do in individual circumstances. That's the proper orientation of the DMAC roll you want to have within the eye for easy tap and unfolding maneuver. So we've done some work on using membrane blue and this has become our preferred technique of using membrane blue because visibility is key in DMAC. And membrane blue outperforms vision blue or the gentian violet available dyes to provide you the best visibility in DMAC surgery. And we published there. And this is a typical postoperative image of a patient who's had a DMAC procedure for early corneal decompensation combined with the phaco. So more than 60 to 70% of our cases are all combined surgery where we do the cataract and the transplantation on the same sitting. We do not sequentially do these procedures. It's all combined as a triple. So we talked about EK in general. We defined EK. We looked at indications and various examples and disease conditions which affect the human corneal endothelium, including dystrophies and PBKs. We described the technique of DSEC as to how a conventional DSEC was formed and how very quickly it got phased away by better versions of DSEC technique, and how they do improve the visual outcomes, both refractive and visual outcomes. And then we went on to describing the DMAC technique. So one of the challenges with these procedures when we start to learn and follow is the risk of complications. In a PK, you do not get that many immediate postoperative complications. With good supervision, with 18 to 16 sutures secured onto the graft, immediate postoperative complications could be pressure IOP related and very rarely suture related because you've got quite a few sutures which are forgiving. In DSEC and DMAC, one of the big changes from a PK surgeon to an EK surgeon is the fact that you've got to be on your guard in the early postoperative period. By the time you get your technique right in terms of positioning, attachment, the air tamponade, and early postoperative management, it is a few cases and a few months if you're doing repeated of such grafts. So the early postoperative period was very challenging and is still very challenging for all learning DSEC and DMAC surgeons. And these are the reasons why it is the graft detachment rates have, I've been very conservative here to actually provide you something what is acceptable norm with these two procedures at the current state of affairs. In the early period, people were facing anything up to 30 to 50% of graft detachment rates, depending on which reviews and what papers you read. And still amongst big learning centers, where there are quite a few learning surgeons, DMAC detachment rates have been reported to anything between 30 to 40%. Early rebubblings. It might not be total detachment, but partial detachments and things like that. But things have become much better. So these are the norms as to what we think we should be aiming towards in terms of graft detachment in the early postoperative period. When I say early postoperative period, it is anything up to a week, 2 week period. After 2 weeks, if the graft's been totally attached, it's very unlikely that graft will move. So just be aware of that particular time period. Primary graft failure, a graft which has been transplanted and is attached, and failure to clear, failure to ensure that the host transparency recovers, or the graft never clears, and the host never clears for up to 4 to 6 weeks. That's termed a primary graft failure. So the graft's not working. And that could happen to multiple reasons. It's not to do with eye banking. It is not to do with only with the endothelial cell density, but because there's so much handling which goes on with DMAC and DSEC, early surgical experience and quite a lot of manipulations in preparation, storage, transfer, positioning, and in the early postoperative phase, all these factors could influence the graft failure rates. So one has to be extremely careful. It's just not the rubbish endothelium which you put in. People look at endothelial cell density, oh, it's 2,500, 2,200. But if it's managed very well, you can actually make sure that you can cut down the variables which can lead to this significant problem. When it happens, it has to be a regraft. Rejection rates, as I said to you, compared to PK are much less compared to PKs. PKs are traditionally reported as 10 to 15%, and depending on the length of time that these patients been and PKs have been followed up. But generally, 1 to 5 year results are very commonly available for DSEC and DMAC, and rejection rates are up to about 10%, but usually about 5 to 7% in our own series, and much less with DMAC. And this is another added bonus with DMAC, which was considered to be a rejection-free procedure. That's not the case, but it is certainly less than DSEC in the right way. Intraocular pressure problems still persists, and is one of the big bugbears for any corneal transplant surgeon using topical steroids. It's still up to 15%, and we do see, particularly during the COVID times, we have seen a couple of patients with delayed follow-up with significant cupping and loss of visual fields to a massive degree with an RAPD. So you can never underestimate this as the potential risk in the early few months. There are traditional steroid responders whom we have to be very careful about, but there are unknown steroid responders who've been using steroids unduly for longer periods than necessary, and they can end up having complete vision loss. And it's a shame to see these patients repeatedly happening in our practices. Well, one has to be extremely careful to watch out and treat them and taper the steroids accordingly. Endothelial cell loss, because of the nature of the procedure itself, compared to PK, EK procedures have been noted to have more endothelial cell loss. Whether this equals to many more of these transplants going in for late failure, we don't know. The field is still relatively young. We're not seeing a huge amount of resurgence of DSEC failures, but still this is something which we have historical data with PK, so we can compare as graft registries around the world, like Australian, UK, and American registries, which are very well organized, which can tell a lot of these things down the line. So I've put together a few things like late failure, infection, visual aberrations as other complications one could be facing with EK procedures. So, again, OCT is a very useful technique to have. It's an anterior segment OCT. It's very helpful in the early postoperative periods to look at graft detachments or early partial detachments in DMAC. And so this is where we are, and we have thin Desect techniques and DMAC techniques. And the question was asked a few years back, about 4 or 5 years back, saying that, it's not as bad. We're not seeing a huge difference between these techniques. And there was a trade-off. DSEC had less complications in terms of graft detachment, whereas DMAC had much more risk of graft detachment. Okay, you might get better vision with DMAC, but the detachment rates were very high 5 years ago. So questions were asked saying that, look, what is the true difference? Do these complications somehow compensate for the vision advantage in DMAC? And is there some standard that we should be following? Is there some evidence for it? And now we have plenty of evidence. So we put together a randomized clinical trial about 2015-16, and we completed it, just recently published in Cornea. That's our recent publication. And so we asked the typical question, which other people have also published on. There are at least another 2 such studies available, where it's comparing DMAC to the best form of DSEC procedure, which is the thin DSEC. So there's ultra-thin, microthin, nanothin, it all depends on what you define as thickness. But sub-100 micron DSECs to DMAC procedure. Is there a real difference in vision? Is there a real advantage in terms of complications and things like that? So what we showed, we looked at a controlled population of simple decompensations without ocular comorbidities, and typically only involve the fuchs patients in this trial, and this being the commonest indication. So we didn't include any other endothelial decompensators such as the pseudophakic bullous, severe bullous keratopathies, aphakics, and all the other severe cases of bullous. We didn't include them. We looked at the simple bullous keratopathy patients, and we compared them with 2 different procedures, randomized them. The results are, very, very telling. Even in the select population with good surgeon experience, controlling many factors such as variables, and including the grafts that goes in these patients, DMAC outperformed thin Desect procedure in relation to vision. This is our trial results. So they were not equal. DMAC definitely, starting from month 1, had better vision, compared to Microthin Desect. Now, Microthin Desect wasn't too bad, as you can see in the table there. The visual results are 6/9 plus, so they are not too bad. But when you are very particular about getting the fullest visual potential for early decompensated corneas, DMAC is the choice procedure. Compared to many other of such randomized trials and other reported studies on DMAC, we did not face that many complications with DMAC. But having said that, a surgeon here was much more a senior surgeon, has passed the learning curve and things like that. But we did not report in the randomized trial on a sequential multiple grafts being done one after the other. We did not see that many graft attachments. In fact, we saw one graft attachment in each group, and primary failure rate was very limited. It's a smaller group, but still, and the vision-related quality of life questionnaire did not differ between them, but the instrument that we use to differentiate between these two groups perhaps wasn't the right instrument to use. That was the reviewer's comments, and I think we agree with that. So I think summarizing it, when you are looking at it to learn these techniques, I don't think as a budding corneal surgeon you can do away without DMAC. You've got to learn DMAC. At the same time, there is a good role to have Desec in your armamentarium, and I'll tell you why. Now, the trial results, the randomized trial results, are very clear. 2 out of the 3, or 2 out of the 4, or 2 out of the 3 randomized trial results are in favor of DMAC for vision. So if you want to give the best to your patients, you've got to DMAC these patients. But not for all eyes. These are for uncomplicated eyes. DMAC is the choice procedure. But the complications related to DMAC soars high in eyes which are complicated, which has got complicated anterior segment anatomy, such as anterior chamber lens, shallow ACs, aphakia with broad iridectomies, previous trabeculectomies, where you can't establish a full airfill. You have multiple iris defects, eye syndrome patients, significant bullous keratopathy with lots of posterior stromal corrugations, which will impede attachment of a DMAC graft, glaucoma tube procedures. Including those, I've added other things which are must in my view, but like deep and very deep anterior chamber. Now, mostly myopes can be dealt with DMAC, but very deep anterior chambers, you're really looking and you're fishing out for your role, which goes into the AC and the angles. Post-viti eyes. So you've got to watch them out. Unless you're thoroughly experienced and you have the confidence to give the best to the patients, generally better to stay away and give them a thin Desec procedure, where the chances of success, attachment, and postoperative complications are much better and reported to be much better. It's a case of eye syndrome. Even after peeling the epithelium and the anterior stromal scarring, it's still visualization is very poor. So there is no macho in doing DMAC in these eyes. I'm very conservative. I quite look at, that patients should have one procedure and get the best out of these. And quite a few of these patients and their retinas are compromised in other ways. So we're not chasing 6/6 in these eyes. So there is a compromise to deal with. So it is very important to realize, whilst there might not be a role for penetrating keratoplasties in these eyes, definitely DMAC is not the answer for all patients with corneal endothelial decompensation. So, Ritika, can I just stop and ask you, is everything okay?
Yes, sir, perfect.
Good, okay. Thank you. So I'm happy to take some questions if you want, but I'm happy to press on to finish the next few slides.
I think maybe you can just finish it, sir, and we'll take it for the end, or would you like me to ask a few right now?
Right. Why don't I finish while I'm on the roll? Okay, so then I'll take questions. Have you got many?
Not too many, sir. I think
Okay.
You've clarified most of the things.
Good. Okay. Right. So we talked about the DMAC technique, the complications, and we looked at the role for Desec even in the best of DMAC eras. But this is a very important slide, and as postgraduates, as we are beginning to learn EK procedures, It is extremely important. It is not one factor, the fact that you can peel a Desmos membrane, or the fact that you can cut a Desect graft very thin, or you could actually do the surgery properly in terms of attaching the DMAC. There's so many maneuvers which you have to learn to become a good DMAC surgeon. That alone doesn't result in good outcomes. Assessment of patients who need endothelial keratoplasty from the time of preoperative assessment in relation to vision, the corneal status, their ocular comorbidities is equally important, if not most important, in making that judgment call as to what they are suitable for, what is the timing of intervention which is good for the patient, what is the choice of procedure which would give them the best visual potential without more complications, and how do we manage them in the post-operative phase. So it is so important that one has to pay particular attention to each of these preoperative, operative, post-operative, and long-term factors. So in a patient, when they come to you, if we start thinking in each one of these box terms, one wouldn't go wrong in actually doing the right choice for these procedures and doing the best for these patients. It is one of my favorite slides, which I portray wherever I go. And I think it's so easy to get drawn into the techniques and the surgical, complexity of the procedures. One loses the whole plot in actually not picking that patient's right, or not choosing the right procedure for the right cornea. Okay, so it is most important until you're trained sufficiently where you can actually deal with quite a lot of difficult and advanced cases with your surgical dexterity. It is important to pay attention to what is the norm in looking at these individual factors. Okay, so pay particular attention to all these aspects if you want to get best out of any EK procedure. I've thrown some literature which might be useful for you to actually read about. So Santosh gave me this topic, and he said, well, you should also talk about what we can expect in the future. And I think it's very important, and particularly with COVID times. The reason why graft numbers have gone up everywhere in the world is because of EK procedures, because we are doing these procedures not when they are visually compromised to 660 and 636. We are doing them when they are 6.9s and 612s. So selection criteria for EK, which is in itself a big lecture by itself as to how do we select and what the criteria and thresholds are, is totally a fascinating subject to discuss. But the reason why we're doing so many EKs is because early intervention in these corneas, but that's going to be compromised because of COVID times. We do about 100 transplants here, but we've done about a handful of them in the last few months, because we haven't got access to corneal transplant tissue for various reasons. It's not just the availability of donor corneas from deceased individuals, it's the access to care homes, the hospices where people die and donate, the consent issues, people retriever issues, transportation, you name it. In every pathway of actually securing and procuring a donor cornea has been hampered by COVID times. So we're going to be facing a significant mountain challenge in the next few years to get through the patients who are building to have a EK procedure. So where do we go from here? So people have talked about DSO or DMAC, where just a Desmos is being stripped, but nothing's being done. People don't. There are some anecdotal cases, in fact, plenty of them, where the cornea clears after an accidental a tear of the Desmos membrane in the central cornea. So people got very excited about it and thought this might be an option for very early corneal decompensated patients with gutta or interference with their visual quality. That's the basis behind the DSO procedure. The Japanese group, Kineshito's group, have already published 2 papers on human trials, first-in-human trials of using cultured corneal endothelium to recover endothelial function in pseudophakic bullous keratopathy without having to strip the Desmos membrane. They actually removed what they call the diseased endothelium without interfering with the Desmos membrane substrate. So there are There are other alternatives available. There is a use of ROCK inhibitors with and without endothelial cell therapy. There are two commercially available ones, the Repressa and the Repasodil. Still, we don't have good corneal data on them, but they are coming. There are some randomized trials available. So the DSL procedure, it has got. Am I too enthusiastic about it? I don't know. And I haven't got a huge amount of experience in actually doing DSOs, but we'll have to watch it carefully and cautiously. The biggest advantages I see here, if you select the patients right, and if it really works for these patients, the patients don't need any steroids postoperatively. You've just peeled a little bit of Desmos membrane for them to regrow and to establish contact inhibition. There's no need for steroids, which means there's no need for monitoring these patients. Patients does, if you look at literature, many of these patients take weeks, 4, 8, 10 weeks before any kind of useful vision recovers and returns. So we'll have to watch and see. There are some standardization which happens in this field. People are looking at 4 millimeters as a standard rhexis diameter peel technique as compared to scoring with or without the Repasodil ROCK inhibitors. So in desperate terms, we might have to look at this very carefully to see which patients might be suitable for just DSO procedure. So watch this in literature and long-term outcomes. This is another fascinating area, and we've been doing some trials for the last 7 or 8 years in this field to see whether there is a feasibility to translate the laboratory trials to human trials. And as I mentioned to you, Kineshito's group have already done 11 human patients, and it's worth reading in journals. So typically we ask these questions, saying in the human trials, Desmos membrane was left intact. But we ask the questions in the laboratory models, is the Desmos membrane really required to do the cell therapy? Say, for example, you inject endothelial cells. Does it really require the Desmos membrane as a substrate for formation of monolayers? No answers have been found so far. The human trials do have the Desmos membrane present. Can we reliably make ex vivo cultured human corneal endothelium, which will not do adverse effects to the trabecular meshwork, go elsewhere, form epithelial ingrowths, and all sorts of side effects? Will they form a monolayer? Will they adhere to the posterior stroma? And can we, when we anatomically have replaced this, will the function return? Can cultured endothelium behave like normal corneal endothelium, which are post-mitotic and have a typical pump function? Okay, so all these questions need to be explored, and we looked at this in carefully each of these questions in a PhD project. Costa now has actually gone off to Shanghai. He did a fantastic project. He completed his PhD about 3 or 4 years ago, looking at each one of these parameters in cadaveric human corneas, where we established bullous keratopathy model, where the entire Desmos membrane was reliably and totally removed. There is no doubt about it. So then we have a nice bullous keratopathy model. We have cultured cells, again, with a typical phenotype of human corneal endothelium with the established markers there. And we injected a certain aliquot of these endothelial cells in certain medium in controlled fashion, gravity-induced settlement of these cells for a 4-hour period onto human bullous corneas, and to keep them surviving in the eye bank in controlled environment in terms of the incubators and things like that in the lab, and see that it can form an endothelial monolayer. You only have to allow a week's time, and what appears to be a clump of cells on the posterior corneal stroma finds the posterior stroma as its substrate and migrates and forms a monolayer. And all other cellular processes like apoptosis and removal gets rid of all the other unwanted cells. And very encouragingly, we saw that these migration of these monolayer of cells didn't extend into the posterior sclera, which is encouraging. It was limited to the posterior stroma. So there is some benefit in believing that cell therapy could become the norm, but we need more trials. We need more clinical trials. We need to know how well we can grow these cells and how easily it could be available for different parts of the world in terms of transfer and transportation. We are living in COVID times. So whether this will truly become a clinically viable technique to surpass, to supersede DMAC and Desec, I don't know. And I think that will be the question. There might be a role for these endothelial cell therapies. And if there is any organ which can accept a cell therapy model and can be visualized and followed up, cornea is a fantastic model to try this and trial this. So I hope there will be more human clinical trials, and hope we will be part to that kind of trials, but time will tell. So that, to a certain extent, summarizes my, talk about the future of what we can expect, in three big chunks: the DSO procedures, endothelial cell therapy, and the pharmaceutical agents such as the ROCK inhibitors and other things which could come into, cause to recover this period of lack of donor cornea availability. So I'll just think of a couple of slides. So I think I typically I finish with this. Say, I think we might we have to walk the way, and I think we are walking the right way. With all these techniques, particularly PK has been a revolution, and you look at PKs for 100 years, and suddenly somebody comes up with this kind of a fantastic idea. It's transformed millions of eyes to see better. So I think, as budding surgeons, as young ophthalmologists, one always have to look out for opportunities to improve and find better ways to actually practice our profession. When I trained in India, again, I see this repeatedly. I do miss, I wasted a lot of time not traveling. And as young postgraduates, never miss an opportunity to look into the breadths of what India could offer, north, south, east, west. I still have regrets, which I'm still making up for it. So ophthalmology is important. EK is very, very important. And learning and distance learning is important, but equally important is traveling. And I hope you all enjoy the time. And I know this coming up to the Festival Lights, so happy Diwali to everybody. And I'm very happy to take questions. Thank you.
Thank you so much, sir. That was really, really a wonderful lecture. And as you rightly said in the beginning that we would enjoy it over a cup of tea, this was quite soothing and calm, and an enjoyable evening at the end of the day. So, and I think you managed to generate a lot of interest among the young ophthalmologists with the questions that you raised. So there are not too many questions on the platform, but I'll take some of the important ones. What is the difference between DLEC and DSEC and DMAC that you spoke about?
Okay, but I mean, DLEC is it's it's an umbrella term. Like what we know about what we call deep anterior lamellar keratoplasty. So basically, you remove the anterior lamella of the cornea, which includes the Bowman's membrane, the anterior stroma, as deep as possible, and you replace it with donor anterior lamella. And lamella is a term used so much as an umbrella term for lamellar keratoplasty or selective keratoplasty. You take lamella and you replace the lamella of the in the cornea. So DLEC used to be a very old term when these things were being looked at. A deep posterior lamellar keratoplasty, and you'll be amazed to see how many variations of technique there were during those days as to how people were defining the posterior lamella. But a deep posterior lamellar keratoplasty means either DSEC or DMAC now, where you are actually creating a posterior lamellar graft and transplanting it to a cornea which is devoid of its posterior lamella, removed surgically. Yeah, does it make sense? So there is no, they mean the same. It is a posterior lamellar technique, whether it's DSEC or DMAC or DLEC, it is a posterior lamellar technique. And it's based on what kind of surgery you use. These are the variations of a posterior lamellar technique.
All right, sir. The next one is about the importance and significance of curved interface femtosecond laser-assisted procedure in DSEC.
Yeah, I mean, it's been tried. I'm not entirely a big fan of it, and it's been tried, and I don't think there is a significant advantage to it. And typically what they do is this, they use a femtosecond laser to cut the posterior lamella. And, in fact, femtosecond laser with a newer iteration, and I didn't go very much into the femtosecond laser talk, is femtosecond laser with the new corneal modules, particularly the Victus is the one which we use. With a corneal module, you could actually do a Desmos cut, right? So it's all being, that femtosecond laser is used to do what manually or a microkeratome does, in the sense that you use a femtosecond laser to cut the anterior lamella off and then refine the posterior lamella instead of using a microkeratome. The technical challenge comes using a femtosecond laser is you're typically dealing with very advancedly bullous corneas. They are in culture. When you have donor corneas in culture, they are swollen. Most of them are devoid of the multi-layered epithelium, and they're cut corneas, and they're usually in the 600 to 700 mark. Okay, despite using dextran in the mediums, you can get very thick corneas which has got stromal edema in them. Femtosecond lasers do not cut in swollen corneas very well. You might be using a lot of energy, and you might be thinking, what is the advantage? Because yes, it might be possible using this as a surgical tool. Okay, when you have a femtosecond laser, you extend the indications to do all these things. But as you rightly pointed out, this is a technique which has been available and has been published before, but I don't see a significant advantage to it. You don't go deeper than what we can normally achieve by current techniques, and you're not any more safer than what we are at the present techniques. Yeah. I'm very happy to take a contrary view if there is anybody who wants to, who are very pro femtosecond laser, particularly for DSEC. Santosh, are you?
Not at all. I don't. I'm an oculoplasty session.
Right. Okay. Far away then.
Very far.
All right, I'll take the next question, sir. Is there a correlation between DMAC graft diameters and the postoperative central endothelial density in patients with Fuchs?
I don't know what that question means, but certainly I think I don't understand that question. I mean, there is the larger the endothelial graft, people have argued that you're transferring more endothelium to the patient's cornea. I think that's what they mean. I think that is true. I mean, that used to be the case. That's why people were looking at actually transferring a 9.5 millimeter DMAC graft. And there are certain Fuchs corneas or bullous corneas which are quite bullous all the way to the periphery. And so for all these anatomical advantages, you could think that you could put a large endothelial graft. But with experience, many centers who practice DMAC routinely have come to realize it actually causes more detachment risk. Anything beyond 9 millimeters or 8.75 millimeters, in my view, increases your chance of detachment more, even if it's not a total detachment, partial detachment. And it is a bit of a bore. You're trying to cover the peripheral corneal bullous cornea, and you end up having a peripheral detachment, which is not doing what you intended it to do. So I have limited my DMAC practice to 8 to 8.5 millimeters. And I see very, very, very hardly ever detachments in simple cases. So you can see. But it is true that if you transfer more diameter, obviously you're transferring more endothelial cells. But it comes with a compromise. One has to be aware of that.
So what do you think is the usefulness and the necessity of an intraoperative OCT?
It is helpful. If you have it, it's very expensive to have. Zeiss has got the Resume, and we've used it in a few cases. It is very helpful, particularly in very opaque corneas or not so clear corneas. When you're doing a DMAC procedure, the scroll orientation is very clearly documented by OCT. Now, I've not included those in the presentation. because I don't want to complicate and too much into it. But an OCT, intraoperative OCT, has got that benefit of it. If your visualization becomes poor and Ritika, can you hear me?
Yeah.
Yes, sir.
Okay, so so that's the advantage of having an intraoperative OCT. When you're stuck, when visualization becomes poor, when the cornea becomes quite, what was a clear cornea, or reasonably clear cornea, suddenly becomes very opaque and you can't see through them. If you switch the OCT on, you could see the scroll orientation. And you can easily pick up the scroll orientation using intraoperative OCT. Equally, we demonstrated a sign where we showed that in Desect corneas, you could very easily identify the stromal side up in using intraoperative OCT. You don't have to have a mark. Okay, so there were some very good advantages for using intraoperative OCT, but it comes along with a significant cost. Okay, twice the cost of having a microscope in your theater. So that's the cost of having an intraoperative OCT.
All right, sir. One last question. In a young patient, what would be your preferred surgical technique? Would you differentiate between DSEC or DMAC or anything else if it's a young patient, or depending on the age of the patient?
Okay. I mean, certainly, I think young patients, if they are symptomatic, they need to be picked up early, and one should not allow the cornea to decompensate more. Say, for example, if you see a young onset Fuchs patient who's phakic, you look at the cornea, you look at the visual decline, you look at the contributing factors which are cornea-related, variations and things like that, is to not allow that cornea to lose its stromal health with progressive corneal decompensation. That's what you're trying to avoid. And typically, in the current situation, we are looking at DMAC as a choice procedure for these patients. If they become centrally and significantly decompensated, even if it's a moderate stromal thickening with gutta and visual aberrations related, a DSO procedure could be an option for these patients as an initial trial, particularly if it's centrally located, rest of the corneal endothelium is normal. But equally, you want to look at saying that if this patient's peripheral endothelium is good enough, why is it not good enough to repair the central decompensation? People could argue that you need to actually take some Desmos membrane off to induce the lack of contact inhibition to allow the cells to proliferate, because inducing injury in the endothelium or the Desmos membrane is a triggering factor for proliferation in the post-mitotic endothelial cells. So that could be the argument to consider a DSO procedure. If it fails, you actually do a DMAC. Whether we combine that with phaco, removal of the cataract or the removal of the clear lens is another matter. Okay, whether there will be a therapeutic that might be available in early decompensators to use ripacidil or something like that to actually prolong the requirement for a surgical intervention is another aspect to look at. So until we have good clinical trials to document DSO or ROCK inhibitors in these patients, if they are struggling to see, work, read, and do their day-to-day activities, DMAC is the choice procedure. And DMAC fails, you do another DMAC.
Okay, sir. Thank you. I think all your videos and pictures really illustrated the surgical techniques beautifully.
Thank you.
Yeah, there are no more questions to be asked.
Thank you, Madhavan, for a wonderful lecture and a very useful evening spent with us. Thank you so much.
Santosh, thank you very much for having me, and all the best with your program.
Thank you so much. Bye then. Good night.
Bye now.
Good night. Happy Diwali, sir.
You too. Happy Diwali.
Good night. Oh, good night, everybody else. Bye.